Hi, I would like to thank Dr. Seckin and to all of you for being here. It's really humbling to talk among the endometriosis giants. And again, some of the things that I will talk about are maybe controversial. It's just I'll tell you how I handle patients in my own practice. And in some of these areas, there is there's not enough data to come up with long-term conclusions, and some of them there are controversial data. And like most of the time when I see a patient, usually I ask this patient about her teenage years. And it's interesting that almost like 95 or more of the endometriosis patients that I see, all of these women have a history of severe dysmenorrhea, often started at menarche. I mean, most of the time they go to the ER and, you know, they were school days and stuff like that. Usually I see the patients right around here. And by their 20s, chronic pelvic pain becomes prevalent. Late 20s, early 30s, first laparoscopy and diagnosis is usually performed. By this time the patient has her own insurance and becomes more independent of her parents. And by 30s and 40s, multiple and usually ineffective follow-up laparoscopies and experimental medications are performed. Part of the reason is, again, you got to understand that we have very few experienced surgeons like in this room. I mean, most of these patients will be handled by a number of OBGYNs who would do maybe one or two endometriosis laparoscopies a year, and that may be part of the reason. Usually they are treated with oral contraceptives, and depoprogestin, and Lupron would be introduced by then. And again, between 20s and 30s, there would be repeated treatments with GnRH agonists, and usually these patients end up with either LAVH or BSO by this time. Again, a couple of principles. I believe that the most common form that endometriosis comes about is through retrograde menstruation, and usually these abnormal cells that exist in maybe 10% of all women, they end up in the pelvic cavity and they populate these areas, albeit small in numbers. They have some stem cell characteristics, and again, if they remain on certain areas of the peritoneum, we call this peritoneal endometriosis, and there might be population of corpus luteum or hemorrhagic cysts that later turn into endometriomas. Probably this is the most common mechanism. And then if there would be repeated episodes of cells that are falling into rectovaginal pouch, again, when a surgeon looks at it, it looks like really invasive. That would probably be the most common mechanism of rectovaginal nodule. Again, the most probably prevalent and obvious mechanism that contributes to endometriosis is ovulation. We still do not understand how ovulation contributes to endometriosis, but as a result, ovary makes these estradiol and progesterone, and they are the hormones that affect either endometrium or endometriosis. Usually at the time of pain, their effects are more striking. And again, in these endometriotic implants, they respond to estradiol and progesterone through persistence, growth, and inflammation. This is important because, as you know, when we disrupt ovulation through GnRH agonists, continuous oral contraceptives, or high-dose progestins, this is a somewhat effective treatment in some of these patients. This is sort of what I usually handle the patients in my practice. If there is undiagnosed suspected endometriosis for patients presenting with dysmenorrhea, dyspnea, or chronic pelvic pain, I usually perform a pelvic exam and vaginal ultrasound. If there is an endometrium or a rectovaginal nodule, either by history or exam, I refer these patients for laparoscopic resection by an experienced surgeon. Usually this is one of the surgeons who do at least 4 or 5 of these cases a week, and these are resected because this group is not going to respond to medical treatment. We know that. If I do not find any endometrium or rectovaginal nodule, I usually offer these 2 treatments to the patient, challenged by a continuous oral contraceptive or diagnostic laparoscopy, again resection. Again, this is the key word, by an experienced surgeon, very important. And either after surgery or if the patient has not responded to oral contraceptives in a satisfactory manner, I put them again on either long-term oral contraceptive, or in this case, I think this arrow should come here, I would add an aromatase inhibitor to see if this would help. And if that's not going to help, again, the patient may be referred for repeat surgery, Lupron, Lipo, or Danazol. But the important thing is the first surgery should have been performed by an experienced surgeon, so there wouldn't be any questions that everything that could be done was performed. On the other hand, I think these are the real difficult patients. If the patient has a history of endometriosis through a previous laparoscopy, it's a fairly similar algorithm. Again, I think endometrium and rectovaginal nodule should be handled by surgery, and a long-term oral contraceptive use is my first line treatment, and then I would add an either aromatase inhibitor, and rarely I sort of go to either Lupron or Danazol. Usually a repeat surgery may be another viable option. What are the response rates for pain relief? It's very important to distinguish the 2 types of patients. The treatment-naive patient who hasn't seen any endometriosis physician, or patients who have chronic endometriosis and who had previous bouts of therapy. In the absence of, again, a rectovaginal nodule or endometrioma, response rates to laparoscopic surgery or medical treatment in treatment-naive patients are very similar. I mean, most of them respond to these treatments, almost 90 to 100%. And pain recurs in about 90% of these patients within 2 to 5 years after discontinuation. Again, I think this is sort of like my opinion that's combined with the literature. On the other hand, response rate to surgery or medication decreases in previously treated patient population. Average response rate is probably much lower, around half in this case, and pain recurs much earlier, like within 6 months to 2 years after discontinuation of this group. So I'll talk to you about the case of refractory endometriosis because I think this is the real challenging group. And we define it as endometriosis previously diagnosed by laparoscopy, pain not responding to recent medical or surgical treatment attempts. And usually the options for these patients include medical treatment, laparoscopic resection or ablation, or LAVH plus BSO. Laparoscopic resection is important. It allows assessment of the extent of disease, should be performed by an experienced surgeon, very important. resection is superior to vaporization or fulguration, we know this through now randomized studies. Unblocked stripping of cul-de-sac peritoneum in the absence of any obvious disease sometimes help as the last resort. Rectovaginal dissection should be considered especially for dyspareunia in these cases. Again, even the rectovaginal nodule has not been like demonstrated. Oral contraceptives is probably they are still underutilized, and we'll come to that. And these are some of the medical treatment options. And these are the progestins. Again, I rarely use progestins because if a patient has not responded to oral contraceptives in a continuous manner, they rarely respond to progestins in my practice. And GnRH analogs have been used more broadly in the past. However, I think the current alternatives, such as oral contraceptive plus an aromatase inhibitor, are probably similar. They give similar results to GnRH analogs with respect to medical treatment. And again, danazol, this is almost like a tiebreaker. The moment I mention a patient androgenic side effects, the patient runs out of my office. So it's sort of, I mean, for those of you who can give danazol, I congratulate you. I can't. I mean, it's sort of very difficult to convince a patient that his cost-benefit ratio is better. Ineffective treatments, endometrial ablation, it doesn't work. Hysterectomy without oophorectomy, again, it doesn't work. Luna doesn't work. In my opinion, progestin IUDs, they have no advantage to continuous oral contraceptives. Probably they produce inferior results. And again, presacral neurectomy just by itself doesn't work. Again, if some of these things could be like Luna or presacral neurectomy would be performed through like effective resection of endometriosis, that's a different story. Experimental treatments include aromatase inhibitors, either letrozole or anastrozole in their doses that are used for breast cancer. Aromatase inhibitor only in postmenopausal women is the treatment of choice for these women. Aromatase inhibitors are usually combined with oral contraceptives or progestins in premenopausal women to suppress ovarian activity. We'll come to that. RU46 at 5 milligram doses per day, much lower than the abort-efficient doses, have been reported to be effective. And again, we recently have some of the other selective progesterone receptor modulators or anti-progestins such as ulipristal acetate. What are the principles to use an aromatase inhibitor in a postmenopausal woman? It's very straightforward. The use of an aromatase inhibitor suppresses aromatase in the peripheral tissues and also in endometriosis. That's how it works. Because these women are already menopausal, its effects on the brain are not consequential. In premenopausal women, if you would use only an aromatase inhibitor, at least theoretically, you might be able to induce ovarian folliculogenesis. A certain number of these women develop ovarian cysts that ruptures and causes some unwanted side effects. That's why most of the time I stay on the safe side and add a continuous oral contraceptive or progestin to an aromatase inhibitor. This was one of the original studies that we performed. We combined the aromatase inhibitor letrozole with norepinephrine acetate. These patients were all resistant to or refractory to existing treatments, and the pain scores went down in the majority of the patients, and it was significant. Again, I mean, this was the only study that we looked at before and after the extent of endometriosis. This is endometriosis, mostly peritoneal. We did not have any cases of, we didn't treat any cases of rectovaginal or endometriosis or ovarian endometriomas for the obvious reasons. And again, we took tiny biopsies, but we did not resect the entire endometriotic lesions in these patients, and this is the same patient, same location after treatment. The obvious criticism was that these patients were also treated with norethindrone acetate that suppressed ovulation in addition to letrozole, but they have not responded to norethindrone acetate or oral contraceptive use before we introduced this treatment. These are the pain scores of another group of patients who were treated with anasazole plus an oral contraceptive. This is another approach, and again, these are all refractory patients who have not responded to any other surgical or medical treatments in the hands of the referring surgeons. And again, the pain scores decreased in the majority of the patients in a gradual manner. And in very few of these patients, we achieved full pain relief, but they all said that the results were satisfying to them. And after we stopped the treatment, in the majority of the patients, the pain recurred. This is another randomized trial which was performed by a Turkish group. I do not have any direct link to this study, but what they did was they compared in treatment-naive patients the use of a GnRH agonist only versus GnRH agonist plus an aromatase inhibitor. And again, in 24 months, the pain recurrence rates were much lower in the GnRH agonist plus anasazole group who received this treatment for 6 months versus the GnRH agonist only. And these are the pain scores again, and you can see that the combination group did much better with respect to pain scores. But with respect to bone loss, at 24 weeks, for example, the addition of an aromatase inhibitor caused more bone loss, and then these patients, they recovered some of this bone loss, but there was less bone loss in the GnRH agonist only group. Anti-progestins are interesting, and as gynecologists, I think we are the only group who use progestins more prevalently than any other physicians. And we are all familiar with these medications, like MPA is Provera, norethindrone acetate is Agestin, and they are progestins, and they show some beneficial effects, in my mind, primarily through suppressing the pituitary and ovulation. And progesterone antagonists, on the other hand, pure antagonists could not be used because of their toxic side effects. So the pharmaceutical companies came up with some of these medications. You are all familiar with RU46, and this medication is ulipristal. It was just introduced in Europe to treat fibroids, and I think it has all of these medications have they have a great potential to be used in the treatment of endometriosis. Amenorrhea in majority of these patients are achieved either through anovulation or direct endometrial effects. Pain relief possibly better than progestin-only treatments. The only concerning side effect is that they cause this cystic glandular dilatation, often associated with both admixed estrogen and progestin epithelial effects. It's a sort of a bizarre endometrial histology. The endometrial thickness is usually related to these glandular dilatations, so you cannot follow up these patients through like vaginal ultrasounds, through endometrial thickness measurements. I just put everything together and just list some of the speculations that I have regarding the disease endometriosis. I forgot to emphasize one point. Like when I put a patient on continuous oral contraceptives, it's very important to educate these patients and set their expectations. Most of the time I tell them that their pain is going to decrease gradually. I usually give them a pain score, and if they look at the pain score and they go through oral contraceptives, and at the end of like 6 months when they come back to see me, if they compare the original pain scores to their current pain scores, I think that helps. I also set their expectations for breakthrough bleeding. Most of these patients, almost 60%, will achieve either minimal breakthrough bleeding or amenorrhea by the end of 6 months. I usually use a oral contraceptive regimen that has 35 micrograms of ethinyl estradiol plus 1 milligram of norethindrone. That sort of works the best in my hands. And that increases compliance of these patients for oral contraceptive regimen. I think that the symptomatology of endometriosis represents a spectrum of a broad chronic disease involving a basic pathology and pelvic tissues, including the endometrium. The disease becomes initially manifest in the so-called primary dysmenorrhea in teenage years and advances to laparoscopically visible endometriosis later. Again, this is probably the majority of the cases, maybe 95%, that occur through Sampson's mechanism. Sampson's hypothesis explains the majority of the cases of peritoneal endometriosis, rectovaginal nodule, and ovarian endometrioma. In epigenetically susceptible women, the risk of development of endometriosis or in the symptoms increases in direct proportion with the number of ovulatory menses a woman experiences. Long-term suppression of menses with oral contraceptives in young women with primary dysmenorrhea should decrease the risk of symptomatic endometriosis in the upcoming years. It would be clinically beneficial to view pelvic symptoms associated with endometriosis as a spectrum and broaden its definition to a systemic disease characterized with pelvic pain responsive to hormonal suppression or surgical resection of endometriotic tissue. So I think this would be more helpful to, in a global sense, to handle these patients, because to sort of tell this patient that either you have or you do not have endometriosis, although she continues to experience pain, which is either hormone responsive, is not helping with the patients. It may help with some subsets of patients, but when you look at the entire group and see this from a public health perspective, it's an interesting different view. And I'm going to stop here, and thank you so much for providing me this opportunity.